Well, I'm going to go ahead and get started, Dr. Mathews. I want to respect your time. I'm just going to introduce you real quick, and then we have some questions. This is just going to be a informal Q&A. I'm going to ask some questions, and if anybody else has questions, you can put your hand up or just jump in, or if you feel more comfortable typing a question in the chat, then I can read it off of there. But Dr. Mathews is a wealth of information. She's been doing this for a very long time, and she's one of the most knowledgeable and experienced MDs in the field. She's a professor of pediatrics and neurology and vice chair of clinical investigation in the Department of Pediatrics at the University of Iowa. She began her research career in basic science, and she contributed to the genetic mapping of FSHD. She then transitioned to clinical research and is funded by the NIH and the CDC, in addition to serving as a primary investigator for many industry-sponsored clinical trials and foundation-supported studies. She sees both pediatric and adult patients with a wide range of neuromuscular diseases in clinic and has retained a strong interest in pediatric FSHD over her career. And I feel very fortunate having talked to her a few times over the years and been in a few conferences with her. And I want to thank you so much, Dr. Mathews, for taking the time after a long day in clinic to be with us today.
My pleasure.
So I just kind of want to start out. The European Neuromuscular Conference was held in October in the Netherlands, and it brought together clinicians and researchers and a few other some ethicists and some regulatory folks from Europe and the United States. And the whole point of the conference was to talk about pediatric FSHD. And a few important things I think came out of that that I would like for you to talk about, Dr. Mathews, if you would, about kind of the what we agreed upon with the verbiage for FSHD, kind of the continuum of FSHD and why that's important, and then the subcommittees that were formed from that, and one of them being developing the clinical care guidelines for pediatrics.
So thank you, Ellie. I'll start by talking a little bit about the continuum issue because my thinking about this has evolved over many years and as the field has evolved. So I think that when we first had the ability to do genetic testing in FSHD, we knew that there were people who were more severely affected and more mildly affected. And as neurologists, we tend to try to slice and dice and describe different groups and categories. And then when we were able to do the genetic testing and show that they all had the same basic genetic underpinning, there was still an interest in understanding the full breadth of the disease spectrum and identifying hearing loss, Coats disease, more severe other disease manifestations as part and parcel of some people with pediatric FSHD was really important. And then as time has gone on, in my opinion, and Allie knows I'm not shy about sharing opinions about this, but as we have moved to an age that we're starting to think about therapies, we are not doing anybody any good by slicing and dicing, by trying to say, well, there's this group, and then there's this group, and then there's this group, because we run the risk of a therapy being only for this group. Whereas if we, as a community, refer to this as a spectrum disease that has different manifestations at different ends of that spectrum, I think that inclusivity is going to, in the long run, be the best for having the highest chance of offering therapies to everybody who might benefit, including children. So, and I think having said that, I think that there are times that there are specific research questions that are best focused on, I'm interested in studying what the basis is of hearing loss. So I'm only going to study those people who have hearing loss or something like that. You can have specific research questions that you analyze a subset of people with FSHD, but you identify that subset in your research question. So I think that the bottom line at the end of the several days of discussion is that I think, and I'm not unique in this feeling, and people agreed, so that we try to get rid of the terminology we have already gotten rid of the terminology infantile FSHD, but even getting rid of early onset FSHD, and just refer to FSHD and then describe different populations. The other reason for doing that is I worry, and you may have opinions about this, I worry that we've scared, to some degree, we've scared pharma off from pediatric patients, because I think they have this mental image that all pediatric patients are severely disabled and we can't include them. So that's
Right.
the spectrum question. Do people have comments about that? Does that make sense? Does that resonate with you?
How does non-ambulatory fit into all of that in your viewpoint as well?
So there are non-ambulatory people who become non-ambulatory at different ages. Some people become non-ambulatory early on during childhood. Some people become non-ambulatory in their 30s, 40s, or 50s. So if you're interested in studying the non-ambulatory patient, you define that population. I don't know whether I answered your question.
Yeah, more along the lines of, the fact that they're also being left out. So it's not only just children, but that
Got
subset
it.
is also being left out as
Yeah.
well. So, is it in the viewpoint is that they're at the floor. So there's no hope, or the therapy is not going to be able to prove that is going to do anything for a patient like that. Is that actually factual? Like, once you stop walking, a therapy is not going to help you at all?
I think it depends on the therapy and the disease. So in FSHD, if muscle is missing, if it's gone, if it's not just atrophied, but it is gone and it has been replaced by fat and fibrosis, then it is not likely that muscle is going to come back. Can you salvage muscles that are teetering on the edge? Can you make muscles that are still there healthier and potentially stronger? I would like to think yes. We don't, as you know, we don't have a therapy, so I can't tell you what's going to happen. But your point about non-ambulatory patients is a good one, and it's one that we struggle with across neuromuscular diseases. It doesn't matter which disease you're talking about, essentially. And it's the balance between, if you are too inclusive and you can't show change, then you potentially kill the drug and nobody gets it. So the clinical trial population usually needs to be a pretty small defined population so that you demonstrate effect. And then if you make the argument that this is one biological disease that there's no reason that if you lost walking a week ago, or are going to lose it next week, biologically it's the same disease and you have the same possibility of benefit if the risk is acceptable. Does that make sense?
Yeah, it does. It does. I wish that we would talk more about the fact that just because you're not walking doesn't mean you can't still lose, or that you can still benefit and gain. And I think that there's a lot of misconception out there that once you stop walking, you've hit the floor. When in actuality, when you hit the floor is when you hit death.
So, right. And I think that that was something that we talked a lot about at the conference, is that our outcome measures, there was one of the consensus conclusions was that outcome measures need to focus on upper extremities. That there is, at least in part, that that's important. There are other outcome measures that are important in FSHD besides walking.
And effectiveness and value to a patient can be just the most minimal, littlest indication. It doesn't need to be this monumental, like I took a step. It could be that my finger moved better. I gripped
Right.
something harder. And I think there's not enough of that talk of I lift a glass to my mouth easier. Like little tiny things make a massive impact in a patient who's been suffering.
So there are a couple, one is that patient-reported outcome measures are increasingly being used. Two, we do have experience with this in something like SMA. So in spinal muscular atrophy, where we have proven dramatic treatments, we have been able to get insurance to pay for those for people or young adults who have very minimal movement, and exactly what you're talking about. If I have patients who can twitch their finger and that's how they propel their wheelchair, and they're on a tracheostomy and ventilator full time, we've still been able to get therapy because that twitch of the finger is so important. Number one is having a very effective treatment and being able to prove that you have a very effective treatment.
Great. That makes
Um,
perfect sense. Thank you.
And Dr. Mathews, I just want to go back to continuum of disease. So we know that the mechanism of FSHD is the same, right? You're born with the disease, whether you start showing symptoms when you're 6 or when you're 60, it's still the same disease. So yeah, there is some concern about how much the muscle has atrophied or how much fat infiltrations got into it, to see with questions about how effective the drug would be. But it stands to reason that if it works for one person, it'll work for the other because the mechanism is the same. And to Kristen's point, even if you're in a wheelchair, most people still have muscle to lose. I think everyone still has muscle to lose. And there are trials that can be run, like you said, if they all want to concentrate on a very narrow population, but they can run parallel trials and other trials outside of the main trial that won't derail it, like you said, that can show efficacy and safety. And then that in turn would help broaden the label, help physicians like yourself get insurance reimbursement for that if they have some data, correct?
Right. And so from a pharmaceutical company, the risk is if you go in, if it really depends on how safe your drug is. If you go into a population for whom the drug is riskier, if you have a death, we just saw this in Duchenne or limb-girdle muscular dystrophy, you have a death that is potentially related to your therapy is put on a very strict hold. So it's that balance of you want to prove some safety and efficacy, and then you would like to be able to study it, perhaps not placebo controlled, in the broadest possible population to get the broadest possible label and provide therapy to anybody who may benefit.
Right, because we do run the risk if it's only studied in a narrow population, even if it gets approved, it's going to be hard for those folks that fall outside the inclusion criteria to get it prescribed and to get it reimbursed, correct? So
And
then now
that's the
they're
balance.
waiting, so now they're waiting years, perhaps, and they're the most vulnerable. Normally they have them, if you're in a wheelchair for any amount of time, a lot of people have respiratory issues and stuff. They really do have a more risk. Their risk benefit is different because their life is threatened,
Yeah.
So I know there's a lot of nuances there, but I think it benefits the whole community when more populations are studied. So then down the road, if you have some data on that, then everybody will have access to the treatment, correct?
That is the goal.
Yeah. So, I wanted to transition a little bit into, so parents sometimes ask, why would I take my child in to get them clinically diagnosed or genetically diagnosed if there isn't a treatment? You know, we've kind of talked about clinical care guidelines. You mentioned a little bit about hearing and coats and some respiratory things. So why would it be important for, if say it's in your family and you suspect your child has FSHD, why, or even not, you know, something wrong with your child, why is it important to get them in the clinic and get them diagnosed and get all those other support systems?
So, in my experience, there's a lot of familial variability about that. In my experience in familial FSHD, it's not uncommon that families know within the first 6 months of life that their child is affected. And they may or may not take them into a doctor. Very often in families, I have the parents tell me their kids, they're pretty sure they've got it, but it's not really affecting them. They're not, you know, they haven't, it's not affecting them socially, things like that. So I honestly cannot, this is not what you want to hear, Allie, but I can't tell a family you have to do that. From a scientific standpoint, I think that it is beneficial to, I mean, it's certainly beneficial to the community if people are willing to enter data into the registries, if they're willing to enter natural history studies. We don't have enough natural history information about children with FSHD, and when our natural history starts when they're having problems, then we really can't describe the full trajectory, so we don't get a full picture. That's the, you know, from the community standpoint, from the individual family, that they may not feel like they want to medicalize their child when they're having no problems for the good of the community. Certainly, it's important in the young children to make sure that we check their hearing, that we have them see an ophthalmologist, those sorts of things.
So
Um,
while there are no treatments, like there's no medical intervention, there's a lot of other things that can be done. Like I'm not suggesting this is a personal family, you know,
yeah.
I agree with you 100% on that, Dr. Mathews. But what I'm saying is, what if there's no medical treatment, but there's a lot of other treatments that can be given to make sure that their eyes are good, their hearing's good, that their respiratory is good, their heart is good, that they get the supports at school, things like that, that go to PT or an OT that can sort of help mitigate some of these more severe comorbidities that are down the line. Do you agree with that?
I do. There is some, for some, you know, if you in your family, you know that it normally doesn't manifest until you're 20 and you have a large repeat, the argument is less easy to make. Um, However, what we often do is try encourage people to come in once. Let's look at it. Let's try to answer the question. You think they've got it, maybe they don't. Let's try to answer the question. And then once you have the information, you know, we've done the testing, you have the information, then if a trial opens up, you're not waiting to get into it if you're interested in doing that. And if the child has enough weakness that they would even be a candidate for a trial. We often have people who, but if something new comes along, you at least have the information and can be informed. You can enter your data into a registry. And then I will sometimes see people every 2 to 3 years. You know, you don't have to come see me every year. If you're having no problems, you know how to find me, you're educated, this is in your family, it's a dominant disease. You don't have to see me every year, depending obviously on the age of the kid and assuming that the child is completely healthy. So it's really, that's one way to if families don't want to overly medicalize their kids. This group, I think, tends to have, I'm assuming most of you have children who are more severely affected. And I'm referring here to the children who are less severely affected. The more severely affected, obviously, we see every 6 months.
So in your opinion, if a pharmaceutical says they don't, they're not keen into going into pediatrics because there's not that many pediatric patients, is that because a lot of them are not diagnosed? Or do you think there's more out there than are on the books, so to speak?
Oh, yeah.
So the numbers are underrepresented. So if
I
a,
think, yeah, I think probably the significantly affected are not underrepresented. I doubt that I mean, families that maybe are starting to get a hint when they're 18, but I think that if we had a therapy, I think we would have a lot more pediatric patients come to clinic. Families would want to have their kids tested.
so if it wasn't in the family, say it's a spontaneous mutation, it's a de novo, would what in a family comes into you, you diagnose them with FSHD, what recommendations, how do you talk to that parent, those parents, and what recommendations do you give them to treat their child?
And that kind of goes back to, I didn't really answer your question about the care guidelines, but so the total FSHD care guidelines have been being worked on for a couple years, sort of overall. There was a consensus at ENMC meeting that the Netherlands meeting, that we needed to pull out the parts that were really specific to FSHD and try to make it a one place that you could, without sifting through pages and pages of general FSHD guidelines, but have one place that you could go if you have pediatric FSHD, where can I go to get information and receive appropriate care? So there's a working group that is working on those guidelines. The general guidelines are hearing evaluations until the child is old enough to, in school and participate in the classroom, and you're pretty sure that they can hear things, between parents and teachers can hear. Ocular ophthalmologic evaluation at diagnosis, and then as determined by the ophthalmologist based on what they see. And education to the family. I think at least an ECG. I don't think most people are going to do an echocardiogram at diagnosis, but an ECG. A young child can't do formal PFTs, but observing their breathing, listening to their crying, deciding whether or not it really depends on the amount of weakness. If the child is significantly weak, you're going to do a sleep study if they can't cooperate with pulmonary function testing. And then talking about the adaptations for school, and you guys, I'm preaching to the choir here. You guys, your kids I think, have already been through that, I'm guessing. So starting to try to provide as much education to the school, talk about adaptations that are needed, depending again on the age of the child.
So Coates disease, if it's caught early, it can be corrected, correct? Like, so if you bring your child in, it has FSHD, and you send them to an ophthalmologist and like early detection is critical with that and with respiratory, because then they can start doing some BiPAP or cough assist, correct?
Right.
So, would you, if there was a treatment that came out now, let's say one of the pharmaceutical companies came out and it was proven safe in adults, would you advocate for it to go down lower into below 18 to try and preserve muscle as early as you can in these kids, even if they do have severe?
Yeah, it depends on the safety profile, the treatment, the kind of treatment, what's involved, and what data we have. In principle, yes. Um, I definitely want to be able to treat people before the disease gets to the point that we're talking about limited movement. But I can advocate with pharmaceutical companies to gather the data to allow a broader label. I have no control over what the FDA says, and then it's all, I'm again preaching to the choir here. You guys have lived in the medical field, then it's up to insurance companies. Because most of these new therapies are not going to be things that a family can pay for out of pocket.
Right. Because I do hear that too. Sometimes they say, well, we can get it off label. Well, first they have to get a physician who's comfortable enough with the treatment to prescribe it off label. And then most times if it's prescribed off label, insurance isn't going to reimburse it. And then again, you have to be independently wealthy to afford that.
Right.
Um, what kind of conversations do you have with parents who maybe they know that their child has it, maybe they've been tested and they haven't told their child yet that they have the disease? Do you ever talk to them about how to have that conversation with them about what is like age appropriate conversation with maybe a 10 or 11, 12, 13, 14-year old about the disease and things like that? Like what kind of conversations have you had with parents?
So generally telling them that, I mean, if they're 10 to 12, you're not telling them something they don't know. So the most important thing is to create an environment that they can ask you what they want to know and trust that you're going to give them an honest answer that answers their question. So I, yeah,
Well, and
early
that's
on,
my
you,
point. There's a lot of several parents that I've spoken to, their kids are, 10 or 12, and they elected to not tell them, but it's a good point what you just said. They are falling behind their peers and they're not certain why that's happening.
right,
So if they have the information, in my opinion, it gives an explanation. Like Kristen's daughter was when she was really young, having a hard time going up the steps of the bus, and she didn't know why. And then once she found out, she's like, "Oh, well, now I know." And I know as a parent, I pushed my son. I I pushed him up and down the street on a bike, like, "Why can't you ride this bike?" And he fell and was bloody, and I kept pushing him, pushing him. And then afterward, I was like, "What have I done?" Because I didn't know. Well, kids are going through that too. They know that they're falling behind their peers and they don't have an explanation. So I'm just wondering if you had talked to parents and that they've had that conversation with them so that gives them a medical explanation of why they can't quite keep up.
right. That's what older kids, young kids, 5, 6-year-olds, you answer what questions they ask you, and then the obvious entree to that is, why are you going to the doctor? Why does the doctor do those things to me every 6 months? So yeah, you have a muscle disease and the doctor's going to help you function. A 10, 11, 12-year-old, there you can, what things are you having more trouble with? Can we talk about those? Are there things that aren't going well at school? Why are we going to the doctor? And yeah, occasionally I'll have families that don't want me to talk about the disease in the room. It's like, well, that's a little bit awkward. But so we try to have a heart to heart about why that's important.
Right, like why is it a dirty little secret, right?
Right,
That's,
right,
it's like they know there's something wrong.
right.
So, and kids I think are more resilient than a lot of parents give them credit for.
And they just want honest answers. They just want to know that they have a parent they can trust and someplace they can go for information that they can trust. And if parents lie to them, then they've lost a critical source of trustworthy information.
So you've been at this for a while. I know my son was diagnosed, gosh, 15 years ago now. Things have changed, evolved in the pediatric. Like I know, like when he first was diagnosed, they told me like, don't let him exercise at all. You're going to destroy the muscle. What things have changed and evolved as we've understood pediatric or FSHD in general, but specifically with pediatrics? Like, what advice do you give parents now, and how has the field evolved like compared to 10 or 15 years ago?
Yeah, I think with FSHD, I think the more you use the muscle, the better. I think I've always seen that people can get stronger up to a point, or can at least maintain strength through using it. So it's one of the diseases that we encourage exercise. The pathophysiology is not a muscle membrane breakdown problem, so it's not the same as Duchenne's. So we certainly don't discourage exercise. I think the biggest in neuromuscular in general, I think the biggest impact has been probably from cough assist and non-invasive ventilation for people who need it. So in having kids cough at every clinic visit, they think it's stupid, but they can't do it. But having kids cough at every clinic visit is something that I didn't used to do once upon a time, but certainly do it now. Um, um, I wish we were farther along. The things with FSH that I wish we were farther along, obviously, aside from just treating the muscle, I wish we were farther along at managing musculoskeletal pain in FSHD. And in my experience, the only thing that works is physical repositioning and changing your environment to minimize stresses and pains. And then I wish we had a better way of stabilizing shoulder blades to be able to have better function, since often it's the mechanical problems around the shoulder blades that impact upper extremity function, at least early on, rather than just weakness.
How do you
We
feel
don't have
about
those developed.
like how do you feel about like surgeries for like tendon transfer surgeries if their foot's rolling, or like they have foot drop and they want to loosen the tendons, or you know, there's a lot of different surgeries, like they're pretty quick to want to do like spinal fusion surgeries or scapula fusion. How do you
Yeah.
feel about that with kids?
I think we don't do much. Well, let me back up. I think the one that's unique to FSHD is scapular fixation, and I think that in my mind it sort of went through, like 30 years ago, it went through a wave of let's do this on everybody, and then it was recognized that a lot of times when you did scapular fixation, your force vital capacity fell, and a lot of people, there were great results, and then there were people who had chronic pain or just not great results, and that it's big honkin' surgery. So I think that one, if you've got a great surgeon and who's very experienced and you're a great candidate, is an option, but it's sort of gone through waxing and waning, and I think you've got to do it with great care. I think the scapular spinal fusions in FSHD, most kids don't need it. And I honestly, it's another one of those clinical areas that I wish we had more data. I see adults who have profound hyperlordosis and are in wheelchairs, and I've seen them in their 50s, 60s, 70s, and they don't have, well, 60s. They don't necessarily have any more pain than anybody else, and it looks terrible, but they're breathing okay and things like that. And then we're also doing surgery. We've done it here on some of the kids. So I think that the spine surgery, it's not as straightforward as scoliosis and spinal muscular atrophy, for example. And I think it has to be done with on an individual basis, careful discussion with the whole team. Heel cord releases, things like that. No indication unless you are very confident it's going to improve function, in my opinion. But I'm not a fan of putting knives in human beings. I'm not a surgeon for a reason. So I tend to minimize surgery.
So there's a lot of talk about MRI information now, especially with Springbok. And that kind of ties into physical therapy. Like a lot of parents are interested in taking their child and getting an MRI done. And then could you then use that information from the MRI to inform a physical therapist and occupational therapist on which muscles maybe are stronger or getting weaker, and kind of devise a therapy plan that way? And what kind of physical therapy, what do you recommend for physical therapy?
So in 2025, no, you can't, I don't know of anybody who would, I don't know of any evidence, and I don't know of anybody who would feel that they could take their Springbok images and devise a physical therapy plan around them. Nor do we have the information to be able to use that to predict the future. I think MRI is an incredibly powerful tool. 10 years from now, we may be having a different conversation, but I'm not right now in 2025. I don't think we can use it in that way. Hopefully in the future, and then I hope in the future that MRI will be a great readout for clinical trials, and that could also allow us to take those trials down to younger kids. It could allow us to take trials down to kids who are non-ambulatory. If you have a readout that isn't, you know, how fast can you walk 10 meters, but an objective readout, it could expand the number of the population to be studied. But I don't think we can use it right now for clinical planning.
And you said for the future, so you can't take an MRI image now and predict whether that person's going to be wheelchair bound in the future, correct?
I couldn't.
Okay. So there's a question in the chat. What other recommendations do you have to treat lordosis?
That's a great question, and it fits into the category of that's something that I don't think we have a good answer for. I think it's a huge problem in FSHD. We sometimes will try abdominal binders. Sometimes that can help support people. It can help support pain or minimize pain. But I don't think physical therapy, I don't think we've got great orthotics. I don't think we've got great treatment for the lordosis. So I wish we did.
So what recommendations would you give a parent in regard to PT? Would you recommend that they start a PT program as soon as possible? How often? What type of physical therapist should they go to? Someone who specializes in muscular dystrophy?
So again, if you have 50 of me and you answer 50 of us that question, you're going to get, you know, something close to 50 different nuanced answers. I try to, with all my patients, I think it's more important that they interact with peers and do well in school than that they go to therapy sessions or doctor sessions. So and I don't want my patients to be, they already have a neuromuscular disease. I don't want them to be over medicalized. And if that means if the physical therapist says, well, I need to see you 3 days a week, and that's 3 days a week that you're not participating in school and you're not going over to your friend's house and you're not, you know, online gaming, whatever it is you want to do, that's not optimal to my mind. I love my physical therapists. If you have access to things like pools, depending on stage of disease and what you're able to do, if a kid is able to swim and participate in physical things within their limits, I think they don't necessarily need to go to a physical therapist every week unless there's a question to be addressed. If it's winter in Iowa and you really can't do much of anything and you lose ground and you've got a good physical therapist, you go. In terms of what that therapy program looks like, I think it's got to be individualized again for the kid. And I think the guidelines that were put together 10 years ago are still probably reasonably good. But I don't offer detailed prescriptions for PT. You could get a PT on and they could give you ideas, but I just advise, when I think about it, you treat the whole kid, not just the muscles, and you think about how their medical appointments fit into the rest of their lives and what they want to do. By the time they're 13, they can have a often very loud voice in how they're spending their time.
So do you recommend the use of anti-inflammatory drugs at all? Do you think that's helpful? I know Stanford is starting a stem cell anti-inflammatory study, I think, next month. It's on clinicaltrials.gov. It just hit. I don't know a lot
I don't
about
know anything
it,
about it.
do you know anything about, would you recommend any anti-inflammatory?
Only ibuprofen for pain, naproxen for pain, but no, I don't. I think the studies have looked at steroids. I would be very reluctant to put people with FSHD on steroids. I would not do any other empiric anti-inflammatory on the basis of the inflammation as a part of the pathophysiology. It's downstream, and I don't know that we have any evidence that stopping the inflammation stops the physiology of what's going on.
What about any other supplements like creatine or multivitamins or amino acids? That they published on the registry in Rochester, and there was one group that seemed to do better, and they were taking amino acids. Do you know anything about that? Any other supplements, creatine or amino acids, or there's CoQ10, and there's all these things, selenium that people that's is a big buzz in the community of what you should do and what you shouldn't do about as far as supplements. Do you have any advice or
Yeah.
experience?
So I always preface everything with supplements. When independent investigators have gone in and tested them, often supplements do not contain what the label says they're going to contain, so you have to approach them with some caution. Second is they often cost a lot of money. If you have a choice of fresh fruits and vegetables versus buying a supplement, go with the fresh fruits and vegetables. If you have unlimited funds, I don't know of any compelling, aside from the Rochester study, and that's observational, and you don't know what else. So I don't know, there's nothing that no supplement that I routinely recommend except for vitamin D if you're vitamin D deficient. I think it's depending, taking a multivitamin is reasonable. If you have a protein inadequate diet, and it's 1 milligram or 1 gram per kilo roughly, if you have a protein inadequate diet, adding more protein to your diet or supplements, but if you just take a lot of protein, it's not like it's going to save the muscle. CoQ10 or creatine has the risk of causing kidney injury, so you have to be sure to maintain excellent hydration with that one. It's been in athletes, it's helpful for very quick, rapid movements, but I don't think there's any evidence, even in the sports medicine literature, that it helps with walking, chronic use of your muscles. It helps if you're trying to swing a bat super hard really fast.
Well, Ian Woodcock did a creatine study, and they just released that.
Right.
And it basically said it won't hurt you, other than it could do some kidney, like you
Right.
said, but it's not helpful either, really, from their study that they did. I think he published it, like 6 months ago or something, right?
Right.
Okay. Does anybody else have any other burning questions? I've been kind of taking up all the space here. I've asked all the ones in the chat. I know John is very interested in the gut biodome. Do you have any recommendations or anything in that regard?
nothing aside from general health things that I think we're learning increasingly about the relationship from the gut biome, about the relationship between the gut biome and many other aspects of health. I don't know of anything specific to FSHD.
If you had a family that was newly diagnosed, and is just beginning their journey with FSHD, what advice would you give them?
Um, Registry, FSHD Society, those are off the top. If it's a family that is new entirely to FSHD, so a de novo case or an adopted child or something, and the family doesn't know anything, I emphasize the variability, because it really is highly variable, and that we take each individual and treat each individual as themselves. We know it's progressive, but we treat the problems as they arrive, encourage them to find things they enjoy. You know, depending on age, we talk about career choices. For some reason, FSHD people like welding and cars. In my experience, it's like it's the only disease that I have multiple people who want to be welders. And it's like, I don't know very much about welding, but this doesn't seem like a great idea. But so we might talk about careers and the importance of using your brain, and doing well in school. And
So there's another question here about COPD. Is COPD pretty prevalent or is it just reduced lung function?
I mean, COPD is a very different pathophysiology from the lung disease of FSHD, is that the muscles of breathing become weak, and then the chest can become smaller so that the lungs can't fully expand. Whereas COPD, actually, the balloons in the lung are too big, and it's very different pathophysiology.
So with my son, in my experience, his lung function keeps falling, and he did a sleep study, and now he's on a BiPAP at night, and then he also is on it's a cough assist, but it's a different kind of cough assist. Like he gets on it for 10 minutes, and it like shakes, and then it inflates, and the way the pulmonologist explained it to me was so it inflates his lungs all the way so the bottoms don't get stuck together, because if they don't get inflated, they can get stuck together, then his lung capacity. So it's things like that, right? Just to keep the lungs expanded, and to make sure that you're getting enough oxygen and fully inflated lungs to keep them as healthy as possible. Is that correct?
Yep.
Okay. And that's really, the respiratory stuff is really very scary for a parent. Um, Anybody, but kids get colds, and a cold in a kid with FSHD can turn ugly really quickly. They can get all this phlegm in their lungs, and they can't get it up. So, a cough assist that can pull it up, or getting them to the doctor to get that out, is like it gets, like I said, really scary, really quickly.
And that's for the kids who have respiratory compromise, having a good pulmonologist, pediatric pulmonologist who's familiar with neuromuscular disease, it's huge. Because we really do have great tools for supporting respiratory function and cough, and can often keep kids out of the hospital now. So yeah, super important.
So a lot of parents are asking about when they think that, and I know it's probably impossible for you to answer this question, and we've already talked about clinical trials a bit. When do you think that's going to happen for kids, for them to be able to get into a clinical trial? Or is there anything on the horizon that or anything that you see out there in the landscape that might be better for kids or more targeted towards adults, for clinical trials?
I mean, my answer is I think the whole community is really excited about the option of targeting DUX4, and there are several companies now that are developing therapies to try to target DUX4. If one or all of those work, that would be unbelievably wonderful. That would be really cool. And I think all of the companies that I've talked to are very enthusiastic about trying to move into children as soon as they can. Um, I think that we're doing a lot of things to lay the groundwork for that, to make it easier for people for companies to move into kids. Um, we're doing natural history studies. MD StarNet, we did an epidemiologic study to describe children who have a diagnosis of FSHD based on chart review across geographic areas. So that gives companies an idea of what, if I moved into kids, what kind of population is out there? What would they look like? How can I design a trial? The natural history studies, the MRI studies, I think we are we are light years ahead of where we were I think even 5 years ago. I think we're way ahead of where we were in terms of being ready to do pediatric trials. Can I predict? I'm really bad at predicting. One always wants to be optimistic, but then one doesn't want to over.
Right.
So I think if we have something that shows benefit, I think there will be rapid movement into pediatrics.
Would you recommend, do you think that like the AAV and the is more would help the younger kids because they don't have the immunity to the virus? You think that that's more likely that those kind of
So
genetic.
I think that most of the current therapies are not using AAV to target. They're using different mechanisms
So
to
Epic
target.
CRISPR has AAV, right? And that's, but
CRISPR,
it's epigenetic. Yeah.
we're probably quite a ways away from CRISPR. CRISPR, as currently configured, would also affect the germline. So if you made a boo-boo and you didn't cut out FSHD, but instead cut out an anti-cancer gene, then all of your children would have a cancer predisposition.
But Epic Bio is not doing, they're not doing a CRISPR cut. They're doing in the epigenetic region. I think they're like shoring up methylation, but they use an AAV to deliver that. But it's more likely to the AAV is more likely to them not have immunity to it when they're young.
Adults are more likely to have seen AVD 8 or 9, which are
Right.
the usual ones we're using before, than younger children.
Right. So, what about, and I'm going to put you on the spot here. What about the kids that are very severe, right? And there are a lot of them out there. Not all of them, but there are several out there. Like I said, the risk benefit is a little bit different. So, so would you support parallel trials or expanded access or something like this to get the treatment to these very severe younger folks earlier for a couple reasons? I think ethically and practically. Ethically, it can save their life, and practically, it gathers data that can benefit the whole community. Would you agree with that?
I do, if you're talking about doing first in human trials in the most severe, I think that would be a hard sell for an ethics board. I think that not limiting access based on function is a no-brainer.
Right. Well, right. I think so. It's a no-brainer. I'm not talking about like a phase one necessarily. Maybe you get through phase one, you find, it's safe. But then if you're in phase two, phase three, why not open it up and let these kids have a shot at it rather
The
than 4,
reasons
5, 6 years down the line, right? Because they're deteriorating at a rapid rate and it really is life-threatening. You agree with that?
So the answer is, and I have no pharmaceutical stock that I know of, unless it's part of a mutual fund someplace, but I am, and I don't work for the pharmaceutical companies, but there are risks to involving more involved people. The Elevidus and Duchenne just had 2 deaths in non-ambulatory patients. They got an approval before they did the trial in non-ambulatory patients. If they had done the trial and had the 2 deaths, they would have had a harder time getting the drug approved for anybody. So there is the risk in a more fragile patient, just fragile overall. There is a risk of a company doing an early phase trial, including those, because if something bad happens, it could close the program. So that's the sort of business argument, and really for all of us, because we don't want to close a program that might have benefit. The other side of it is exactly the side you presented, that you want to have some data to support expanding the label and to support arguing with insurance companies. One approach is to not do it at the beginning of a phase 3, but have a phase 3 where after a year, if there's no safety signal, then you have an expanded access for a non-analysis group for safety data. And that's the kind of design that I think we hope companies will consider.
But non-ambulatory in Duchenne is a little bit different than non-ambulatory in FSHD.
I'm just using it as an example of the fact that the more fragile patients may have bad outcomes, and whether it's fragile, I'm using it as shorthand for fragile. Does that make sense?
Yeah, it does. I read this thing with the FDA though, that they did a 10-year study over 10,000 expanded access programs, and there was not in those 10,000, none of them in the expanded access caused a trial that drug not to go get approved.
Mhm.
10,000 in 10 years, because they know that the expanded access patients are more fragile. They know that they don't fit this, but they also know that there's a benefit. So I guess it's like a catch-22. You don't treat these folks and then they die, or they have, they're very severely, because it's severely disabled, life-threatening.
Yeah.
You have to have that to even qualify for expanded access, right? So you have to be severely disabled or life-threatening, right?
There are a lot of different kinds of, you're talking about not expanded access as part of a protocol, but you're talking about outside of a protocol.
Right.
I'm talking about within a protocol.
Okay.
So you
All
can
right.
have
Okay.
a protocol that includes an arm that is not for analysis, but is a safety only
Right.
arm.
Okay. Yeah. All right.
And that's very different than the company gives you free drug to your primary
Right.
care doctor who gives you the drug. So
Okay.
and I favor drug companies, if they've got a promising product, having an arm that is not the analysis arm that you're using, that's the double blind, is this going to work? But once you're a little bit into it and you've got enough safety data to have a non-analysis arm, and I can't remember the
Right.
full name for it.
Right. No, I heard you saying so.
It's a safety
Like,
cohort
right, like
that is outside of
yeah.
the primary analysis
Right.
inclusion exclusion.
Just to collect safety data and all that, so that then when they go to the FDA, they have more data. And also insurance companies will look at this data and say, okay, we know that even though you're non-ambulatory and you weren't in the primary trial, we have this data, so we know that, we could pay for it. It gives the physicians and the patients a shelf to stand on to say, look, they've tried
Right.
it's safe, pay for the drug.
Right.
So how do we convince them to do that?
I mean, it comes down to money. That's an expensive, it's, at least that's one of the things that comes down to. And I'm not, like I said, I'm not in the pharmaceutical company, so I can't answer that for sure. But I think the steps are in place. I think we're collecting the data. You're talking to the pharmaceutical companies. They understand that we need to be able to treat everybody with FSHD, not cherry-picked groups, when we have a therapy. So I think the steps are being taken. The pharmaceutical companies are hearing it. I think de-risking it to some degree by, there are barriers that insurance companies put up that are by age, there are barriers by function, there are barriers by weight. So, what ones do we want to attack? I think the easiest one is age. Because that's a, FDA approval 18 and up is a very common, easy thing that we see. So,
Right.
but I
So,
think the steps they're being done. They may not be being done fast enough, but it takes time to gather information.
right. And, it's just a lot of times I got all these stats in my head, the early onset, what we used to call early onset, symptoms before age 10, right? 40% of them are going to be non-ambulatory by the time they're 17, right? So then they grow up with this, they're non-ambulatory, they reach 18, and then they still are not eligible, right? They're still not eligible to get in a trial. They may not be eligible for treatment because they're non-ambulatory, and everybody's afraid of non-ambulatory. So we're putting them in a position where they're like, damned if they do, damned if they don't. Obviously, if you can get the intervention to them, well, and to preserve muscle before they lose that muscle, before they get in that fragile state, that would be optimal. But then once they're in that fragile state, we can't just throw up our hands and say, oh, too bad. We let you get in this fragile state and now we're not going to help you, right?
And that's where, if I go to other diseases, you prove the drug works in your narrow population. And then we have been able to get it in other populations. And we've gotten insurance to pay for it. But you need a drug that works.
Right.
And works with an acceptable safety profile.
Anybody have any last minute questions for Dr. Mathews?
Yes, I have a question regarding a few years ago, Dr. Mathews in June did a survey about potential gut or intestinal issues with FSHD. My question is, did you find that there was any variability related to the intestinal issues?
So I would say that what we found was that more people with FSHD reported GI stuff, but it was variable. The kinds of things were reported were variable. I think our conclusion was that it's certainly that it was something that needed to be asked about. And that there could be some smooth muscle involvement, but that it's not incredibly common. I'm trying to pull it up. Did that answer your question?
Well, I was looking at the potential of the microbiome causing the variability that we see with different between patients. In other words, some patients may go till the age of 39 and have no symptoms. Is there a trigger mechanism that triggers the symptoms?
Yeah, I mean, there was nothing in that survey that would give us a reason to believe that or not to believe that, because it was really more of a clinical survey.
Okay.
I have another question related to triggering things, if you have a couple more minutes.
Yeah, go ahead.
Okay. So I don't know, it just seems like it's often brought up in the community that hormonal changes seem to be a trigger. And I don't know if there's I think there's probably not many studies done on this, but whether it's puberty or menopause or pregnancy, I'm just wondering what your thoughts are about that. And I guess particularly I'm most interested in I guess the puberty stage. That seems to be around the age where a lot of kids can, can have more progression. And just wondering if for females, if the up and down of hormones monthly might play a role, or if it might be more the just the start of puberty. And I guess specifically thinking about some sort of management like birth control to manage the
Yeah.
hormones.
Great questions. And I don't have the answer to any of them. So that's, but in other diseases, FSHD, one thing that we looked at with the MD StarNet data was age at diagnosis and graphed it, and it was basically linear. So there wasn't a jump. Now, this is age at diagnosis, so there could be a jump in symptoms, but just by age at diagnosis, there was not a jump in. It wasn't like there was a low level of diagnosis in early childhood and then you hit, 10, 12 or so, 8 to 12, and there was a bump in the number of people diagnosed. So doesn't prove anything, but it also doesn't suggest that there's a huge hormonal impact. On the other hand, in across neuromuscular diseases, particularly muscle diseases, I have had women in particular tell me that they feel that there's marked variation in their strength associated with their menstrual cycle. I have tried to think about how to study that, and the bottom line is you've got to be drawing blood regularly and measuring hormone levels, and it's not feasible for me. I don't think we know enough about impact of hormones on disease progression and muscle strength. I mean, we obviously know that hormones cause increased muscle strength at the time of puberty, particularly if that hormone happens to be testosterone. But I don't think we know enough about the role of hormones in muscular dystrophy. I think it's an interesting question. I think it's hard to study. I would not put somebody on birth control for that reason. But I would say most of my female patients with neuromuscular disease who are not trying to get pregnant are on birth control just for management of menses and cramps and feeling like doggy doo-doo. Did that answer your question? I mean, there isn't an answer. It's a great question, but there isn't an answer that I know of.
Okay. Yeah, thank you. I think just, like a lot of things, more studies need to be done, but yeah, thank you.
All right, our hour's up. Any other parting shots, questions? Dr. Mathews, do you have any final thoughts for us?
When I really think about it, I know we don't move fast enough when you're the mother of a child. We never move fast enough, but we are, believe it or not, way farther than we were even 5 years ago. And I think that the drive of Allie and people on this call and parents in general has really changed the environment, sort of the big environment, and that there will be significant progress made over the next 5 years too. We're laying the groundwork. There are treatments in trials that have high hopes for success, And if one of those works, we're going to be in a very different place 5 years from now.
Okay, well, thank you very much, Dr. Mathews, not only for your time tonight, but for all your work that you've done in the lab and then with all the patients with people with FSHD for years. So thank you so much for everything you're doing and for giving us your time. And we'll keep fighting the good fight. And the PEDS Move Plus study is ongoing now, right? They're recruiting, and that is an MRI, blood draw. It's every 6 months. It's very comprehensive. Those are the kind of things you're talking about with laying the groundwork. Those are concrete things that pharmaceutical companies can look at to compare to that maybe will encourage them to go into pediatrics more quickly, correct?
Exactly. The Move Plus, the work being done in Australia, I think we're going to have a lot more information in the next few years.
Right, and there is a lot of information. Like if I did it, I look for early onset pubs all the time. There's like 35 or 36. There's a lot of information out there. It's just now we're gathering different kinds of information, and you know, from our perspective, we just need to keep pushing that boulder up the hill that, peds don't have a lot of peds don't have time to wait. We need to get it earlier rather than later because a lot of them do have life-threatening symptoms, and we need to get the treatment to them sooner rather than later. And like I said earlier, we don't want them to have to wait till they're 18 and their body gets so deteriorated that they can't recover. All right, thank you so much for your time. Thank you all for being on this call. I appreciate it.